deliver some services to their people. We saw the CHR program as being something more than a health transfer mechanism. We saw this as a mechanism to begin to build the capacity of the tribal government to manage its own health program. Now, that was not stated up front, but that was clearly part of the reasoning behind the decision to follow the Northern Cheyenne model. And out of the CHR program, in addition to all the other things that we all know in terms of maternal and child health and safety, and we have also seen the foundation of tribal health departments, tribal health authorities, the very structure of tribal health government has in fact come out of the CHRs. So I guess I'd have to put that transition from almost total federal operation to a beginning to tribal operation of at least part of the program. It took about 4 years from President Nixon's Indian message till there was a consensus within the tribal community, and we were able to get Public Law 93-638, which is the Indian Self-Determination Act, which is essentially the same as President Nixon's original concept in his 1970 policy statement. So we then had gone from sort of an Indian Health Service philosophy of supporting tribes to manage their own program now to a federal statute which gave the federal government the responsibility to do that, and gave clear legal responsibility to the federal government to support tribes managing their own systems, and clear authority for tribes to take over functions. The Indian Healthcare Improvement Act was developed and passed into law, signed into law by President Ford in 1975. That bill was designed to focus on an array of things, all of which fit together in a common package. It seemed to me that we had 638 then as sort of the authorizing legislation. And then we had 437, which really said, okay, now here's how we're going to provide you with the resources. And the priority as to how you're going to build up the system so that the tribes, in fact, then can take it over and operate it. So I've got you up to, I guess, the late 70s. We saw during the late 70s and under 638, and using resources that were coming from 437, we saw a gradual but steady increase in the number of tribes that are operating programs. At the time I retired, we had something like 20% of the service units in the Indian Health Service were being operated totally by the tribes. Those numbers have increased significantly in the succeeding 8 years. The whole dynamics of the program were changed over this period of time, from one where the federal government was the deliverer of care, without question. The tribes were advisors, and a gradual transition over the period of time where, at the tribe's decision, the tribe's initiative, they became the operators of the program, and the Indian Health Service then became, in a sense, the advisors. And the genius to this whole process is that the decision is made by the tribal government. They have to make an informed decision as to how much of the program they want to operate, how they want to operate, and when they want to take it over. And that's, to me, is the essence of self-determination, and that's the place at which I left the program.
Emory, I believe during the early 70s, Indian preference and practice of hiring Indians was accelerated considerably, and maybe you'd like to share with us a little bit about professional development training of Indian people and the increase in the number of Indians in the program.
Well, in the beginning, of course, the number of Indian people trained as professionals was quite small. We had done a fair amount of training in what I would call the paraprofessional or the health occupations. We had I guess from early 50s, there was a practical nurse training school in Albuquerque, and we were training dental assistants and food service workers, and of course sanitarian aides. So there was quite a variety of people being trained that way, but we really didn't get into professional training of Indian people in any substantial way at all until the passage of the Indian Healthcare Improvement Act. Because up until that time, we did not have authority under the law to provide scholarships. The training that we were doing was training of our own staff. We had that authority, but we did not have the scholarship to train non-employees. So the scholarship program then allowed us to do that. And I couldn't give you the numbers, John, but it is very significant, the increase in the number of physicians and nurses and dentists and health records, librarians, sanitarians, sanitary engineers, public health, nutritionists, dietitians, pharmacists. You just go down the whole list of those people who make a hospital or healthcare system work. And hundreds, thousands over this period of time of Indian people have been trained in those professions.
During the mid-'70s or early '70s, I know there was a great number of facilities built and staffed and equipped, and some old facilities renovated. And why don't you share with us how this all came about, and if it came through the Congress, through OMB, or just how these new facilities was initiated at this point in time, Dr. Johnson?
Well, this will require me to make a comment or two about the Office of Management and Budget. That organization, as you know, is a part of the Executive Office of the President, and it's their responsibility to establish the President's budget and the ground rules for his annual submission to the Congress of his budget request. It is my impression in the early days that the Office of Management Budget was never very interested in building new facilities. The early ones that were built, as I recall, when I was still in the field in the Bemidji and Aberdeen areas, for example, and also when I got here in Phoenix, we were allowed to expand a facility. We called them renovations or something or other. But the new facilities were very, very rare. The Office of Management Budget always had a bias against building a new facility, to the point that during the years I was director, John, I don't believe one single hospital or clinic was ever initiated by an administration. Not one single hospital or clinic ever saw the light of day through a President's budget, through the approval of the Office of Management Budget. Every single one of them was identified by an act of Congress.
Dr. Johnson, I believe during this period of time, there was an emphasis placed on decentralization of program management. I think up until the early '70s, let's say, while there was still a pretty strong central management philosophy of the Indian Health Service, and then we came along with a decentralized philosophical approach to management of the health care program.
Well, I think, John, what we saw again is typical of the Indian Health Service as being an incredibly adaptable organism. We tend to do what we need to do at the time we need to do it. At the beginning, it clearly was a very centralized organization. And as a reservation physician, I didn't see the wisdom of that. With my 20/20 hind vision, of course, it's obvious to me that that was the only way that the program could have been managed, simply because you did not have trained people and experienced people out at the reservation level. Dr. Shaw had a mere handful of people with the kinds of skills that you need to manage a program. For example, if we had one pharmacist in a whole area at the beginning, we were doing very well. Now it's an unusual health center that doesn't have more than one pharmacist. So as time gone on, we have driven the skills level, the professional skills level and the management level down to the field. And as the skills level is driven down, then obviously the delegation of authority goes with it. In the beginning, if you had delegated the decision-making process to the field the way it was when I left, we would have had catastrophe because we didn't have the trained, skilled people out there at the time. So it's been an evolving process. I don't think it's fair to say that we went along with a centralized organization, then all of a sudden we shifted. And I was party to this, John, because I was, you know, started at the reservation, and I was in the area here in Phoenix for 4 years, and then I was in Billings for a couple of years, and I was part of that process, and I saw how as headquarters would begin to say, well, maybe those folks out in the field you know, have some ability to handle this and give us the authority, and then as we got comfortable with the ability of our people out in the hospitals and clinics to manage something, it was redelegated out there. But I think the philosophy behind this whole business was that you ought to drive the management level down to the lowest competent level. The closer to the point of action the decision is made, the more likely it is that that decision is to be relevant and appropriate to that circumstance.
Emory, I know there's many things that have taken place during the 12 years that you was director that had some impact on the elevation of health status of American Indians, and one of these was probably the development of Indian health boards at the service unit level, the area level, and even the development of the National Indian Health Board. If you will, share with us your thoughts and concepts of how these boards have played an important part in the management of health services for American Indians.
And we came to the conclusion, it was probably in the middle 60s, that we needed to have a critical mass of Indian community leadership that was knowledgeable in health, because we could see that eventually the tribes were going to be managing these programs, and they needed to have leadership in the community that knew the nuts and bolts of management. So we set up, as you remember, at Desert Willow and elsewhere later on, specific training programs for health boards. Now, health boards were always voluntary on the part of the tribe. In other words, the Indian Health Service, to the best of my knowledge, never created a health board. But we were trying to increasingly encourage tribes to do it and to provide resources in the form of training. And sometimes when we got to the area level, for example, we would provide support so that they could have an executive director and some clerical support and the ability to get together for meetings and do some studies and things of their own. And at one time, you may remember, we used evaluation money. There was a mandate from the Congress that a certain percentage of program money was to be used to evaluate programs. And we made the decision to earmark most of that money, or at least that portion that we had control over, to the tribes, to establish tribal evaluation organizations, so that the tribes, again, evaluating their health program, we felt was not only giving us the consumer's assessment of what they were getting, but also had some tremendous spin-off in terms of the knowledge that was then going back into the community as to what was happening and what their needs were, what needed to be corrected. So again, it's this sort of self-supporting, self-expanding, mutually supportive activity within the community.
Emory, I want to thank you personally for taking the time to be with us today and sharing this 12-year period of time that the Indian Health Service had a rapid growth and a very dynamic tenure. And even as we look forward to greater things in the days ahead from a program that's currently 35 years old. Thank you again very much.
In 1982, after an intensive search of more than 6 months for director of the Indian Health Service, Dr. Everett R. Rhodes became the 5th director. Dr. Rhodes, known as Everett, medical specialty is in the field of infectious disease. Thus, he is no stranger to the need for a total comprehensive health care and services program which covers prevention, treatment, rehabilitation, along with a major emphasis in today's world of health promotion and disease prevention. Dr. Rhodes is the first Indian director of the Indian Health Program. He had also been professionally associated and involved with the Indian Health Service for several years before becoming director. He served in a variety of consultant capacities and was virtually responsible for the development and establishment of the Association of American Indian Physicians in 1970. Dr. Rhodes came to the Indian Health Service from the University of Oklahoma School of Medicine, where he had served as a professor in medicine for a number of years, plus serving as chief of the infectious disease department of the Oklahoma City Veterans Administration Hospital. He has been instrumental in making the total Indian Health Service program more responsive to the health care services and needs of Indian and Alaska Native people at the grassroots or service unit level.
Everett, you have the distinct honor of being the last director of the Indian Health Service and the first agency administrator, because on January the 4th, 1988, the Bureau was elevated to an agency level. And your tenure as director and administrator of the health program, Indian Health Program, has been from 1982 to 1990. 8 years now. Why don't you just take a few moments and take us through some of the major program initiatives and activities that you have witnessed and even been a part of during these 8 years.
John, I guess it would be appropriate for me to reflect a little bit on the context, if I could use that word, of the Indian Health Service in 1982 when I came into Indian Health Service, keeping in mind that I think in contrast to all the previous directors of Indian Health Service, in fact, I was an outsider to the Indian Health Service, the first director to be selected from outside. I'm kind of impressed that Indian Health Service has always been in a state of transition, or perhaps better expressed, in a state of continuous development. And in 1982, there were several currents that were going on in this country, I think, that are significant for the Indian Health Service and in my tenure in the Indian Health Service. One of the things that I've said before about Emory Johnson, among all the other manifestations of his genius, was picking the appropriate time to retire. His retirement coincided with, I think, almost precisely to the first real cutback that the Indian Health Service had ever experienced in its resources. And when I came into the Indian Health Service in February 1982, with impending congressional hearings, all of the discussion was about possible closures, possible furloughs, reductions in force. This also was the wind-up of the year when the hospitals in the public health service had just been closed. Perhaps largely as a result of that, I encountered what I took to be a fairly strong degree of anxiety in the Indian Health Service. I think, appropriate anxiety. And I wanted to be sure to not interfere with the considerable momentum and evolution that the Indian Health Service had exhibited, at least since 1955, when it was transferred from Interior over to, at that time, HEW. I guess stated in medical terms, I really wanted to follow the ancient dictum, first do no harm. I thought I was pretty knowledgeable about Indian health, and as a matter of fact, I had worked fairly closely with the Indian Health Service for a number of years, but I really wasn't prepared for the magnitude of my ignorance in relationship to just the day-to-day operation of this very, very complicated, very vast, rapidly changing program. The Indian Health Service has got many, many dilemmas and ambiguities built into it, I think inherently as part of the program. And as we all know, the line of command, the line of management is from the director to area directors, then to service unit directors, who not only had a responsibility to deal with medical care, but also had a large, ever-increasing responsibility to just simply manage this very, very complicated program. I undertook to sort out those kinds of things in a reorganization of headquarters, which I think in hindsight now turned out to fulfill the true criteria that I had. One, don't do any damage, and secondly, to clarify. A lot of the time that I've spent in the Indian Health Service, not just necessarily a reflection of my one-track mind, I don't think either, but the need to clarify and simplify. That seems to be a continual need. The other element that had begun a few years before I came to Indian Health Service, but had reached a kind of peak as well, was the need to somehow deal with the ever-increasing need for rapid information assimilation and analysis that has become sort of a byword in this country, information systems. Part of the reorganization of Indian Health Service was to locate the development of information systems in its own organization. One of the other principles that really struck home to me when I came into the Indian Health Service, and I think everyone knows that Emory recruited me for this job for 2 or 3 years, actually, in preparation for his own retirement. And what Emory had described to me is sort of encompassed a lot of his own experience in the Indian Health Service, I think, in what he described as Indian Health Service moving from a family business to a corporate operation. That line of reasoning would not lead one to Everett Rhodes, and I told the people that I was not necessarily suited for that kind of role, but would tackle it nevertheless. Those words proved to be very, very true. The development of whatever I mean by a corporate structure for the Indian Health Service had to do with putting in place a number of elements that I think has sort of marked the 1980s.
Dr. Rhodes, you are the first Indian director of the Indian Health Service, and I wonder if you would maybe make some comments about being the first Indian director of the program.
Gosh, you know, like all topics, that's a very complicated subject, John, that a lot of people would reflect upon in various ways. Becoming the first of something is not a mark of very great individual distinction unless one has won a race. I don't want to minimize, however, the very, very important symbolic value, I guess, of the organization of the Indian Health Service having arrived at a point in history, particularly in the context of what was going on in the United States in the 1970s, that it really was mandatory, I believe, for a director to be an Indian. I don't believe it really makes any difference whether one is Indian or non-Indian, as far as participating in or being a director of the Indian Health Service. I felt an enormous responsibility placed upon me that I really needed to perform in ways that would not embarrass the Indian Health Service, quite seriously, but also as a person very, very conscious, steeped in the heritage of my own tribe. Even though I don't look like an Indian person, I really was brought up very, very much in two worlds, I admit that, but with a heavy background in brush arbor, being raised in large extended family in southwestern Oklahoma, heavy missionary influence through the Methodist Church. I felt an enormous responsibility to behave in a way that all that is represented by my tribe and Indian people generally would not have occasion to be dissatisfied or embarrassed or so forth with my performance. That probably represents a certain degree of responsibility that only the first Indian director might bear. It's very real.
Dr. Rhodes, pretty soon after you became director of the Indian Health Service, why, I believe you were involved in the transfer of a number of area directors. This had not been done for a number of years, and I wonder if you would care to comment on some of the problems associated with transfer of area and program directors.
There were two main considerations that I had, John, at that time. That was part of my continuing consideration about clarity of the Indian Health Service, clarity of roles in the Indian Health Service. My impression, correctly or incorrectly, was that the necessarily decentralized operation of the Indian Health Service had come to a point in the history of the Indian Health Service when I think there was a good deal of ambiguity and perhaps a certain degree of complacency among the real managers, and by real managers of the Indian Health Service, I mean the area directors, they each having their 12 areas of the Indian Health Service. Perhaps I was more sensitive about that also coming in, as I said earlier, an outsider to the Indian Health Service, that in my opinion was that there were a certain number of the area directors who were not really convinced that they worked for the Indian Health Service, to put it in just organizational terms. However, I do believe, after talking with area directors themselves involved and other managers of the Indian Health Service, that movement of the area directors, even with the cost in individual terms, has proved to be very, very stimulating to the Indian Health Service. And one of the fascinating things to me was to discover in more than one area director that I was concerned about a move perhaps having a very stultifying effect upon. Quite the contrary, have indicated to me that the challenge of a new location and new responsibilities proved to be very, very exciting and stimulating to them as well. So on the whole, I believe it was a useful thing to do.
Dr. Rhodes, over the years, and certainly during your tenure where the Indian Health Service has placed a great deal of emphasis on recruitment, retention, and training of staff, particularly professional staff, and I wonder if you could give us some comments about what's happening in the Indian Health Service today along those lines.
As you know, John, the Indian Health Service is a very, very special organization in many, many ways. It truly takes a certain kind of individual to be attracted to and to be able to work under the relatively and sometimes severe adverse conditions of working in the federal government as a bureaucrat on the one hand, working in geographic and climatic conditions that are not always ideal for individuals. There's always been a substantial turnover in personnel in the Indian Health Service. That's not all bad. And it waxes and wanes from time to time. We're able to recruit fairly well, at least we have up until the present time. But the problem continues to be able to keep individuals in the Indian Health Service for long periods of time. I view the need for continuing manpower in the Indian Health Service as one of the top 2 or 3 pressing concerns that I think as we go into the 90s is going to continue to be that way.
Dr. Rhodes, we spoke of the fact that the Indian Health Service had been elevated about 2 years ago from a division to an agency level, and maybe you'd like to share with us a little bit about the trauma and the pains that went with the elevation from a division level up to an agency level.
All I can really say is that it was an idea whose time had arrived sometime previously. Indian Health Service had grown to have more than 10,000 employees, a budget approaching $1 billion, which put it at a size greater than for some of the other agencies within the Public Health Service. A series of interests began to move in the direction of elevating the Indian Health Service to what I do believe is a more appropriate representation of the size, complexity, and mission of the Indian Health Service as an integral part of one of the functioning parts of the Public Health Service itself. And the perspective that the Indian Health Service could bring to the Public Health Service with its community orientation, with its comprehensive services, in fact, has been picked up from time to time. And I've heard assistant secretaries, for example, say that one of the things that would be desirable in this country is if some pieces, at least, of the Indian Health Service could be replicated into one-stop shopping. There's a lot of discussion about one-stop shopping in this country. I think those kinds of contributions that the Indian Health Service can make to the Public Health Service, in my opinion, also probably outweigh the direct benefits to the Indian Health Service of being located one place or the other. There is no question but that the special perspectives, viewpoints, requirements of the Indian Health Service can be expressed to higher levels in the department now ever so much more efficiently than they ever could before when the Indian Health Service was a bureau within one of the agencies in which the trail through the bureaucracy was just so long that I think it was rare for officials at the departmental level, except under instances of unusual ingenuity by a director of the Indian Health Service. The message just did not really arrive there. That's not true anymore. I now sit as a director of this agency with the other 6 agency heads, that is the National Institutes of Health, the Centers for Disease Control, and so forth, with the Assistant Secretary for Health every 2 weeks, and offer my viewpoints in relationship to the health of the nation from the perspective of the Indian Health Service from time to time that I can clearly see is a viewpoint that the highly specialized nature of the other agencies doesn't have.
The one thing that has taken place over, I suppose, the last 2 to 3 years that never seemed to happen previously to this time was the fact that the Indian Health Service, today at least, in their top manager, you have more super grade civil service people and assistant surgeon generals in the commission corps than ever before, and that certainly must have some impact on the retention of staff and this sort of thing that you spoke about earlier.
I think it does, John, although the numbers are still very small. As you well know, and unfortunately too many people know, that one of the adverse consequences of being a bureau, and perhaps not related only to that, was the fact that when I came into the Indian Health Service, the average grade, both in the civil service and in the commission corps, was far below the average for the Public Health Service. We had a long ways to go to recover an appropriate level of ranking in the in the Indian Health Service. I made a lot of noise about that. I didn't let people forget about that for a moment. And concomitantly, I think, with the elevation to agency status, in fact, we've been able to increase the flag officers in the Indian Health Service and the senior executive service substantially. Things got so bad at one time that there was a period of time when the only flag officer in the Indian Health Service, in fact, was the director of the Indian Health Service. And we only had one senior executive service individual. Now, all of the area directors and all of the associate directors, with two exceptions, however, because of youth, belong to either flag rank or to senior executive service. We have a long ways to go yet, but I'm pleased with the direction that it's taking.
Dr. Rhodes, in the early days being 30, 35 years ago, the emphasis of health care of American Indians and Alaska Natives was on infectious disease, acute illnesses. However, over the past couple of years, there's been certainly more emphasis placed on health promotion and disease prevention. And why don't you share with us today some of the activities that IHS is currently involved in concerning health promotion and disease prevention?
Yeah, and I think you appropriately describe it also, John, as being a tradition in the Indian Health Service, the emphasis on health promotion and disease prevention. One of the interesting things to me that I've never looked into is that when one reads the Snyder Act, 1921, that authorized health services to Indian people at a time when services were provided in the Bureau of Indian Affairs, the language that is incorporated in part of that is very, very prophetic. And that is that the Secretary of Interior at that time would expend such monies as Congress would from time to time appropriate for the relief of distress and the conservation of health of Indians. And I've gone back to that language many, many times, and in my opinion, in modern terminology, if I could say modern from 1921, that language was nothing more than health promotion and disease prevention, of which I truly believe that perhaps the premier exemplar of that philosophy in the United States has been the Indian Health Service. I think that, again, a mark of the genius of the Indian Health Service has been the balance between providing clinical care with physician and nurses and all of the ancillary assistance at a time when prevention was recognized as really the key to dealing with the health of Indian people. One of the other very, very profound principles that I don't know the exact very beginning of, but I think basically as a result of Dr. Shaw's leadership, subsequent directors' leaderships, and certainly Dr. Johnson's, and became incorporated into law with the passage of the Indian Health Care Improvement Act in 1976, was one of those profound statements that makes the Indian Health Service very, very special and very different and far more exalted, if I could use that term, than other agencies in the federal government, and that is we have a single goal. And that goal is stated, again, in very, very prophetic terms, in my opinion. The goal is not to provide medical care to Indian people. It's far greater than that. It is to raise the status of health of Indian people, to make healthier Indians.
You're probably the only one that can maybe talk about the future a little bit. Past is gone, and yet how do you visualize the delivery of health care to American Indian and Alaska Natives, let's say, in the next 10 years?
There are a number of forces that are acting on all of us in the United States today, but focus very intensely on Indian people because of the special relationship of Indian people to the United States government. Many of these forces are moving Indian Health Services in a positive direction, but not all of these forces necessarily will take us in a direction which, in my opinion, is beneficial for health of Indian people. As you've alluded to a couple of times, the single most important driving force at the present time, in my opinion, in Indian communities is the burgeoning demand for ever-increasing complex array of medical services. The Indian population is increasing at a rate about 1.4 or 1.5 times greater than that of the average growth of the United States population. And I think that this country is coming more and more to the realization that even the United States of America cannot marshal all of the resources that would be desirable to provide all of the medical services that the citizenry needs.
Dr. Rhodes, I want to thank you very much for taking the time to be with us today and sharing some of your wisdom regarding healthcare delivery for the first American.
Thank you, John.
Thank you.